Good morning, everybody. My name is Alexander van Tongel. I'm from Belgium, and I want to thank Manos and Manos for this invitation. It's been a great congress until now. So I will discuss a little bit strategy for preoperative planning for rotator cuff repair. And I will start with a letter that I received from a family doctor. Dear colleague, would it be possible to see my patient as soon as possible? He did a wrong movement on his job. He still can move his arm, but it's painful, and the ultrasounds shows a small, full thickness tear. So this is the typical patient, worker compensation or not. So the question is, in this kind of patients, so do I need to repair it, and can I repair it, and will it heal? So the first question, of course, and I think maybe it is a question that I can send you to the room. For this patient, so it is a patient that had a wrong movement and had pain afterwards. Who would say this is a traumatic cuff tear? That's not a lot, all right. This is a degenerative cuff tear. Yes. That's the reason why I show. But for workers' compensation, there's going to be a traumatic one. So this is going to be for the insurance company. This is going to be the difference, because this patient will say, "Yeah, but I didn't have any pain before I had this wrong movement." So indeed, I think there is very important to make the difference between a traumatic and a degenerative tear. And I would like to refer to this beautiful book of Codman, The Shoulder. He has written it in 1934, where he first described the successful repair of traumatic supraspinatus ruptures. And if you look to his conditions, what he said, what is a traumatic tear, I think we still can use it perfectly. So it means they haven't a traumatic tear in cases where there were no symptoms in the shoulder prior to the accident. It has to be an adequate injury, so a wrong movement is not an adequate injury. It's usually a fall or something like that. And there has to be some loss of power and elevation of the arm. So pain after a small trauma is not a sign of a traumatic tear. And I always compare it like we saw yesterday, also with a shoulder dislocation. If you have an anterior shoulder dislocation in an elderly group, you can have a tuberculous fracture that can be reduced afterwards. Or if you don't see it, well, it's going to be the tear that it's attached to, or it's going to be the tendon that it's attached to that part of the fracture. So that's the reason why we see also in anterior shoulder dislocations, it's really an infraspinatus tear, and we need to check the lag sign immediately in the emergency room. So for me, a traumatic tear is a supra and infraspinatus tear. It's like a tuberculous fracture without any bone fragment. So a small, full thickness supraspinatus tear is not a traumatic tear. So this picture has already been shown. We know that it's an aging process, the cuff. But the question is, so we have this patient. Well, do we know it's the pain is coming from the rotator cuff? So this is also a very nice study that showed that it's not accurate to assume that the accompanying rotator cuff tear is responsible for the tear. So first of all, we need to check to make sure is the tear really the cause of the pain or not. All right, but then we decide, okay, it's going to be, we're going to repair it, and then you see the patient. And this is your patient. You can see it's 56, an active one, or maybe this is your patient. It's also 56, but he has a complete different comorbidities, of course. So can I repair it, and will it heal? So we need to check to the comorbidities, what are the risk factors, and we need to check the overall comorbidities, and we need to check to the rotator cuff. So aging, we know that if we will repair it in elderly people, there is a high chance it will not heal, or it will re-tear again. So a risk factor is certainly age. Obesity is an important factor. There is a significant factor for a re-tear and a re-operation in patients with obesity. Smoking, the results are worse in smokers. It's not detected anymore in patients who quit smoking 6 months prior to surgery, but most of the people will not say you need to now stop smoking for 6 months and then I will do the operation. So most of the people didn't stop at that time. Diabetes is a very important risk factor for re-tear or non-healing. So that's also in the discussion how we need to define this, issue. And then I want to show you this, this patient or this person. I don't know, the French guys know who it is, probably, but that's Goutalier, and I needed to check it up. So we see a lot of the Goutalier classification, but I didn't know how he looked. But this is Daniel Goutalier. So he made his study on fatty muscle degeneration in cuff ruptures that is being used in a lot of classifications right now. So he graded it. He graded it as grade 1, there is a normal muscle. Grade 0, I mean normal muscle. Grade 1, muscle contains some fatty streaks. Grade 2, fatty infiltration, but still more muscle than fat. Grade 3, equal amounts of fat and muscle. And grade 4, more fat than muscle. But it's very funny to see in his first publication, he uses these grades, but how he describes it as stage 1.5 to 2, stage 2.5 to 3. So he doesn't follow his own classification in his own presenting study. So this is the way we classify the fatty infiltration of the muscles on a CT scan. Most of the time it's on this sagittal plane, so grade 1, grade 2, 4. But this is only one 2D image. So we performed a study. What we did is that we made a 3D evaluation of all the muscles, and we asked to the system what is the fatty infiltration of the different muscles. We compare it with the teres major that didn't have any fatty infiltration. So, and if you compare how you would describe a Goutalier classification grade 1, you can see that most of the time it's only on average 10% of the fat that's in the muscle. But even if you go to grade 3 or 4, it's less than 40% on average that's seen really as a fatty infiltration into the muscle. So probably our classification is not perfectly, and hopefully in the future with this new artificial intelligence we really can quantify the fatty infiltration, and so we also can compare our results better. So, but why it's that important, the Goutalier classification? It's because it's shown that if there is a lot more fatty infiltration, there is a higher chance it will not heal. So you can see in the stage 3 and 4, there is a very high chance of more than 70 or even 80% that it will not heal. So I think it's important to evaluate the Goutalier classification before your surgery. And then we have this beautiful picture here of this beautiful rotator cuff, but we need to know where is the tear, because we know that the location of the tear will have an influence also on the situation if it will heal or not. So this is the concept of Burkhardt and Esch concerning the rotator cuff cable. So this is what we've seen during surgery, where you can see the crescent and you can see the rotator cuff cable on top of it. And we know if the lesion or the rotator cuff is the rotator cuff cable is involved into the lesion, there is a higher chance of re-tear than if the rotator cuff cable is not involved into the lesion. So also check if there is some contrast going out of the intra-articular spot to the bursa. If there is an attachment, is the rotator cuff cable still attached or not, or if the biceps is also involved. So then we also look to the retraction of the tear. So we know that there are different sizes of retraction. We have a partial tear, the full thickness tear, small, large, and massive. There is a correlation between Goutalier classification and retraction. So probably these are two variables that can be put in one box. All right, but then, so what we need to do for this patient, the aim is, of course, that we, for this specific patient, know what is going to be his best treatment. And I think it's very important that we start our registration of our patients and that we try to compare our results together. So this is why I present the system REDCap. It's called REDCap Research Electronic Data Capture System. It's an secure web application. It's created where we can send an email to all our patients and we can ask all their different comorbidities. So this is, for example, here in Greek. I put in some Google Translate, so I don't know if all the translations are correct, but it can be used. And then afterwards, we also put some surgical details into the system, so we can describe where is the lesion, what is the retraction. And afterwards, of course, if we have all this data and we really can compare our results from, for example, Greece or Poland or the Netherlands or the United States, then we can put some machine learning onto the system, and then we can really evaluate the risk factors for this specific patient, because this is going to be the goal in the next few years. So to conclude, my strategy for rotator cuff repair, first of all, do I need to repair it? So the question is it a traumatic or a degenerative one? And if there is a rotator cuff tear, is the tear the cause of the pain? And if I think it's the cause of the pain, then I need to ask them a question, can I repair it and will it heal? So I need to check the comorbidities and I need to check the cuff characteristics. And for the future, I think we need to improve our strategy with registration and evaluation. Thank you very much.